After this, we're all going to be super huge fans of GLPs. And I love the GLP talk right before lunch, the thing that I am standing between you and. So I prepared for about 40 minutes. I have 20. We'll get it done. So let's get going. These are my kind of, this is, hey, cardiometabolic disease and management. This is something I have a lot of interest in and kind of passionate about. My kind of alternate titles for this were, GLPs, hey, come for the weight loss, stay for the cardiometabolic disease benefit, Another one was maybe GLPs, not just for a Kardashian anymore. This is a conversation I have all the time in my clinic. I mean, yeah, it's Ozempic, but it's not Ozempic. It's like a branding thing. You know how we call like all facial tissues Kleenex, but they're not Kleenex? So, what I really think about this is this what prescribing Viagra in the 90s was like? Because this is like the hot, sexy drug to have right now. And so I kind of wonder like what that was like. Anyway, so that being said, I sadly also have no disclosures currently. I'm in the market though, so if you have a topic, let me know. I have 4 kids. All right, so this is just a brief overview, some things we'll kind of go through. We'll get from here in a second. All right, so I thought this was neat. How were they discovered? They were initially discovered, the VA research. They were discovered in the saliva of Gila monsters. And so it was interesting because they were found to act similarly to a GLP-1 hormone that we produce ourselves endogenously. So these are not GLP-1 hormones. They are a compound or a molecule that acts similarly and is much, much, much slower to degrade. We degrade our own GLP through a compound called DPP-4 very rapidly. And so this is just a drug that's much, much, much slower to break down. It was originally produced into exenatide, which was Byetta or Bydureon. Anybody remember prescribing Bydureon, where it's like a little chemistry kit? You had to it was like a weird thing to describe to people. So the new drugs are much better and easier to use than that. Also, the nausea was really severe with Bydureon too. Okay, so we'll breeze through this. Long story short is hunger is extraordinarily complex. And the big thing I want to focus on is that where the green box is here on the left side of the screen is this is where the GLP-1 hormone acts. And so this is how its feedback loop into. So this is how the feedback loop kicks into the brain to help shut down appetite, and kicks in to increase satiety. And so also if you look just to the left of that without a green box, there's GIP, which does something similar, and that'll become important for us to talk about another drug later on called tirzepatide. Okay, so this is where the GLP-1, so it's a receptor agonist. So again, it's not GLP-1. It acts on those same molecules though, and again, it's just much more slowly broken down than the endogenously produced GLP-1 that we make. And so, and again, it's resistant to degradation by DPP-4, which is a drug, which is another molecule pathway we take advantage of through the drugs like Januvia as well. So these are the effects of the drug, okay? So number one, first and foremost, it is just will very, very effectively suppress appetite, okay? It's an extremely potent appetite suppressant, and that is how these drugs primarily work for weight loss purposes. And so it's interesting if you talk to people who have chronic obesity, which is a very common thing, a lot of them talk about food noise. And so it's this constant background thought process throughout your entire day where you're always thinking about, what am I going to eat? I'm kind of hungry. I want to nibble on this or that. What's for lunch? Oh, what's back there? The brownies look good. This kind of like constant dialogue you have in your head with yourself. And so, and then when they take this medicine, they're like, this just goes away. Is this what it's like to just like eat a meal and then not think about a meal for hours until it's my next meal time? So it's a very interesting effect. It delays gastric emptying. This is a feature, not a bug, okay? So what happens is when we consume a meal, now we are physically staying fuller for a longer time frame. So this is also helping those feedback satiety mechanisms. And so people also very quickly learn, if I'm going to eat a regular size meal, I cannot eat my regular size meal anymore. It also decreases postprandial glucagon secretion. This improves insulin sensitivity. It helps insulin secretion in a glucose-dependent fashion. So it is making your body more sensitive to the insulin that you still produce for diabetics. It also decreases gluconeogenesis by the liver. So it's reducing, again, endogenous glucose production. And also, talk about that. Hypoglycemia is essentially unheard of in these medicines. If you're getting hypoglycemic on the GLP, that's not the GLP. So this is a huge issue. It's only getting bigger, no pun intended. And so a couple of years ago, the AHA put out this presidential advisory talking about cardiac, kidney, and metabolic disease, this kind of triad. Over to the right is kind of the summation of this: high burden of poor metabolic health, which affects essentially nearly every organ system. Okay, I will also show red maps of how big we are. You have to look with Dr. Sabaya. So this is the obesity map. We've seen this all the time, and so this is not surprising. This is a BMJ article that I found that kind of validated what I said, that I was thinking internally. So this says that about 3/4 of cardiovascular death in the world during this time frame listed was related in some way to metabolic disease. This is a global study. There are a lot of things globally we don't have here. We don't have a lot of rheumatic heart disease like they have in other countries. So our proportion of this is even higher than this 3/4. So that's why I feel so strongly about this topic in these medicines. So there have been several trials that show lowering of CV risk in diabetic patients. This class of medications has been out for a couple of decades. So it's a new topic, it seems like, because it's new in new in media, but the class of medications have been around for a very long time. And so it came out with these listed. Albiglutide is no longer on the market for commercial reasons. I guess I never heard of it until I did this research. And so there's been a very clear relative risk reduction in MACE events and all-cause mortality of about 12%. Reduction in stroke is even bigger, that's 16%. And again, this is in diabetics only. Recommendations are from multiple societies about how to use GLPs in the management of diabetes. So metformin remains a first-line agent. But then, any patient who can't tolerate metformin, you can define that how you want. If their A1C is still 1.5% over the goal after 3 months of therapy, they have clinical ASCVD or clinical heart failure, or they have CKD. That's almost all of them. So a lot of these people are going to be candidates for, a lot of these diabetics are going to be candidates for GLP therapy. So this was kind of groundbreaking. As soon as this article got published, the semaglutide rep texted me that morning at like 7 o'clock, like, "Hey, did you see the New England Journal?" So this came out at the end of 2023, and so this is the SELECT trial, and it looked at semaglutide in patients who did not have diabetes. They were excluded from the trial. And so the inclusion criteria was age over 45, a history of clinical ASCVD. They've had an MI, they've had a stroke, or they have symptomatic PAD, okay? Again, diabetics were excluded. And so the biggest thing with this is they had a hazard ratio of 0.8 for the primary endpoint, which was MACE events. And they also, as an aside, had about an 8.5 or 9% reduction in total body weight. If you see the curves on the trial, they separate pretty early, okay? So it didn't take a year or 2 years for this curve to begin to separate. There's almost an immediate separation when you look at that. So this was another trial that came out a little more recently. This is looking at HFpEF. This is not super surprising, as I mentioned earlier. They help with things like reducing adverse modeling of the myocardium, the ventricle, so that can be very helpful. This was a smaller trial, about 500 patients. They all had HFpEF. So this is not HFrEF, this is an EF of 50% or higher, so not HFrEF. Reduced ejection fraction heart failure. And then they looked at weight loss and change in heart failure symptom scores. This KCCQ may not be something that outside cardiology people are familiar with. This is a very standardized questionnaire that we use in cardiology to assess heart failure patients and their symptoms from heart failure. A higher score means you're feeling better. And so, and it did not assess heart failure hospitalizations, unfortunately. So we look at the outcomes though. So about a 10% loss of total body weight. It showed a significant improvement in the Kansas City scores, which is great. So these patients were feeling better. Unfortunately, again, it did not assess heart failure hospitalizations. Hopefully a trial is coming, because if we can get this approved on the diagnosis of HFpEF, and we can show insurers, hey, look, we can reduce hospitalizations if you will cover this drug for us, then I think that would be a really big help, because in our world, heart failure hospitalization is one of our biggest cost drivers, and trying to avoid that is one of our biggest things we try to do. So For the GLPs and weight loss in general, there are 3 that are approved for weight loss. It's liraglutide, semaglutide, and tirzepatide, or semaglutide, everybody says. Currently the only one that has been approved to reduce FDA approved to reduce cardiovascular outcomes in the absence of diabetes is semaglutide. So currently trials are being done for tirzepatide. I really think tirzepatide is an amazing drug. I highly, I truly believe that this is going to come out and they're going to show really good cardiovascular outcomes too. We just have to wait for that. The average weight loss for these drugs is between 10 and 20%. So tirzepatide, 22%. Bariatric surgery is like 25%. So it's almost like an injectable surgery. And so we'll continue talking mostly about semaglutide because it does have the cardiovascular benefits. So this is Wegovy. Everyone calls it Ozempic. I call it Ozempic again. That's cool. It's Wegovy. So I bring this point up for this reason. If you prescribe them Ozempic under the diagnosis of cardiovascular disease, they will laugh at you. So it's the wrong drug. So you have to prescribe Wegovy. Wegovy comes in these and Ozempic is a dialable pen, almost like Atlantis or that kind of thing. Wegovy is not. It comes in a pre-filled, single-dose auto-inject pen, and it is comes in these doses currently. I suspect Novo Nordisk, those people, man, their marketing people are on top of things. So they just came out with a trial in the last couple of months showing that a dose of 7-something milligrams has equivalent weight loss to tirzepatide. So I have no doubt they will be rolling that drug out as soon as they get that dose out, as soon as it gets FDA approved. But currently the peak dose is 2.4 milligrams. And so you have to prescribe this version. Also, you don't prescribe it for a month. It's 4 pens at a time, and then refills of that. Okay, that's another big thing. If you try to prescribe like a month supply, it's 4 pens. This is another reason that it's commonly denied. So again, it's approved for secondary prevention in patients who have established ASCVD and overweight or obesity. So for weight loss, it has to be a BMI of 30 or above, or 27 or above, with comorbidities associated with obesity. So for this, the ASCVD is the comorbidity, so it's 27 and above, BMI 27 and above. And so ASCVD is a clinical event. So again, PCI, MI, peripheral vascularization disease, or even unrevascularized CAD. Or the big thing now is that they have a coronary artery calcium score that shows coronary calcium, because you need to prepare for that, and that's going to be huge. They have ordered more CAC scores in the last 4 months, I think, than I have the entire time prior to this, trying to find a way to try to get this drug approved. So again, it comes in the pre-filled auto-inject syringe, and those are the doses. So how to dose is an injection that's given sub-Q into a fatty area. The rep told me, and I've been telling people to give shots in the thigh as weight is reduced. Apparently that can become too thin. And so you can get IM that won't last as long. So you can do the belly. The thing with the belly is, if you look at the pen, this little window that comes down, a little yellow bar slide down, depending on your patient's fluffy factor, when they push it in, because it's you don't push a button on the back, you have to push it in until it clicks and triggers. And so if you push it in, sometimes the yellow bar is obscured, and they won't see the bar go down. So anyway, so it's a dose given in a subcutaneous fatty area, push until you hear a click. You hear a second click, you count to 10 slowly. That's it, the whole thing can go in the trash can. It does live in your fridge. You can take it out the night before, let it on the countertop warm up if you want. It's less uncomfortable that way, although it's really an issue. And so the dose is given every 7 days, plus or minus a day. So if you're going to give it on Sunday, you can give it the next Saturday or Monday, that's fine. For semaglutide, the symptoms tend to peak at about 2 to 3 days afterwards. So you can time your dose on how you want to feel. Do you want to have a lousy middle of the week or a lousy weekend? When do you want to be most symptomatic? So you can kind of adjust from there. You can increase it's FDA approved to go every 4 weeks. And in the trials, that's what they did. And the trials, my suspicion is they were trying to show as much benefit as soon as possible. And so they had incentive to ramp up the dose as quickly as possible. That's not what I do clinically. Clinically, I say, hey, we're going to keep you on the dose and we'll stay there until you plateau from a weight loss standpoint.
and we'll monitor how your symptoms are doing, and then we'll increase from there. There's not, in my opinion, there's not a race to get to the max dose like there was in the trials. We can kind of slow roll this, and if we get to 2.4, never, I'm totally fine with that, as long as we get the results that we want. Okay, that's missing part. Okay, so we talked about the effects already, apparently. All right, so then what's interesting about semaglutide is these other things you'll be hoping to talk about. The number of people who are on this medication and tell me, my drinking has just gone way down is really, really interesting. I have no doubt, again, the brilliant minds at Novo Nordisk are investigating this for another approval. So I actually have a guy, he's a wonderful guy, had a lot of health issues, he's doing much better now. He just got married and he saw me last time and said, I think I may get divorced. I was like, you just got married, dude. He said, well, my wife and I were dating, we were going out all the time, going to bars, having cocktails. Now I just want to sit at home and sweat and watch basketball. And so I drink like a bubbly water and that's it, I'm good. So his wife like, I didn't sign up for this. So anyway, there's also reports of less impulse buying, so your Amazon bill may go down. There's interesting small reports of maybe loss of libido. So basically, this medicine tends to be an anhedonic in some ways. So it affects dopamine potentially. And so if you just engage in less pleasure-seeking behaviors in general, again, I think more data will come out about this. And it seems to be semaglutide seems to have the strongest effect in this world. So side effects, they're almost exclusively upper GI or lower GI in nature. It is 3/4 of people will have some degree of nausea, upset stomach reflux. That is just super, super, super common. And I tell them that. And so there's also possibility of constipation or diarrhea. Both of these things seem to be more common in women, especially constipation. There is a very, very low rate of biliary or gallbladder issues. It was 2.6% in the original human journal trial. That was 1% higher than the placebo trial. When you lose weight rapidly, you increase your risk of developing gallstones, apparently. And so that may play a big role. So rapid weight loss can precipitate gallstones. But it's also cholecystitis is a thing as well. 3 of the 1,000 people develop mild pancreatitis. I don't know what mild pancreatitis is. Whenever I see it, it seems major. So maybe it's mild for you, it's major for me, I don't know. But so it's a very, very low event rate again in the trial. So I have seen a couple of people who've had it from taking a GLP, but again, mercifully, it's a very, very low number of people who have it. There is a black box warning. This is one of the biggest things people get hung up on. It's a black box warning, that makes sense. So the way I describe this to people is there's a theoretical risk if you have a personal or family history of thyroid cancer or multiple endocrine neoplasia syndrome. I've never met someone that has that, so if someone in the room has it, don't raise your hand and we'll be afterwards. And so if you have those things, there's a theoretical risk. This is not demonstrated in trials of developing a C-cell thyroid cancer, but it was seen in rat studies, and that's why we have the black box warning for that. So that's probably one of the biggest hang-ups people have is when they do the Googles. The Googles say thyroid cancer. Tips for success for this. Big one is fluid intake. So again, you're just consuming less overall, especially if a lot of your calories or a lot of your fluid is coming from like beer and that kind of stuff, and you're just drinking less of that because you have less appetite or volume or space for it. Then that can be a problem for some people, and that's probably the biggest association with any kind of renal failure, kidney disease they have. Although again, overall, these drugs are overall nephroprotective. It's adequate protein intake. This is a big thing as well because of the risk of when you already have weight loss in general, there's a risk of lean mass loss. So making sure we're having adequate protein intake. I tell folks about 1 gram per kilogram or 0.5 gram per pound of body weight, of ideal body weight. And then engaging in regular exercise or physical activity, especially resistance and strength training, super helpful again to help preserve that lean mass, as well as the other 10,000 things strength training does for you. And then the big thing, people are like, oh man, I'm losing 2 pounds of weight, but I think I can lose more. I'm like, well, bro. So that's the big thing too, is avoiding too rapid a weight loss. And this is again where people kind of want to ramp up if their symptoms are getting better. And like, great, like, what does the scale say? Oh, you're losing, 1 pound a week still. Like, no, we're going to stay where we are. And so then another thing is, a poor woman was on max dose of Wegovy. She had to come off of it for a surgery, and then she had something else. So she was off for like 3 or 4 weeks, and then she gave herself a shot again at 2.4. She was not a happy gamer. So that's a big thing as well. So if they're on it for the longer you're off of it, you may want to consider reducing the dose or even sometimes starting at the original starting dose as well. Common concerns and myths. Weight regain after cessation, that is a real thing. We'll talk about it more in a second, I think. And so, and then lean mass loss, this is my biggest frustration. Whenever you lose weight through calorie restriction, you lose some lean mass unless you take active steps to prevent that. About 1/4 of your weight loss comes from lean mass or non-fat mass, we should say, and 3/4 comes from fat mass. That is not new news. That has been shown in weight loss trials since time immemorial. And so this drug is no different. And so it is not someone, a famous Stanford surgeon who has a book, has been around the social media stuff saying that, oh, in my clinic, it's 2/3 lean mass loss. All right, Peter, publish or shut up, dude, because that's not what the data shows. And so that frustrates me anyway. So that's a big thing. And there are more trials looking at this as well. One is Ozempic-based. This is, I think it was out a while ago. So Ozempic phase is weight loss phase. So if you lose a lot of weight, it's also a bariatric surgery phase. It's also, I have protein malnutrition phases. It's just weight loss, okay? So there's not a specific thing that affects the fat of the face. It's just weight loss. Biliary gallstones, we talked about that. That is a higher risk. The thyroid cancer thing, we talked about that. Again, it's a theoretical risk. It's not been shown in trials so far. And then this new one came out a while ago. This is, I'm not going to try to pronounce it, nor am I going to try to spell ophthalmology either. So it was published in that journal. And so what it showed is that this is a single observational series that showed an increased risk of this disease process. Again, that's not been seen in trials. And so we'll kind of see how that shakes out going forward. But again, what I tell people is I agree that this sounds bad. I can't pronounce it, but it sounds bad. But the number one cause of blindness in this country is diabetes. So that's also bad. So anyway, insurance coverage, this is, oh my God. So this is by far the most challenging part of these medicines overall. Here's what I have learned so far. And if Jeanette was here, she would show you, she has the scars to prove it. So she's my MA who helps me on these things. She's very, very good at this. So the coverage is very challenging. What I tell people is it's going to depend on who your insurer is, and not do I have BCBS or Aetna or whatever. It's who is it through. When your employer, your spouse's employer, chose their insurance, I feel it's like choosing cable in the 90s, okay? Do I want the sports tube package? Do I want the premium packages? That's what your insurer, your employer does. They're going to choose to cover fertility drugs. They're going to choose to cover weight loss drugs, okay? If they choose not to cover it, it's just not going to be approved. And no matter how many times I resubmit it, do prior auths, or send other drugs, it's still not going to be approved, okay? And so those are essentially spinning your wheels. Wegovy does have a QR code and a website to help determine coverage. It's allegedly about 90% accurate, so that can help out figure some of these kind of spurious things out. Some Medicare plans will cover it under the diagnosis of CAD only. There's a bill to try to get in Congress to try to get Medicare to cover weight loss drugs under the diagnosis of obesity. As we all know, Congress is really firing on all cylinders right now. They're doing great things up there. And so I'm sure that's going to go through probably this weekend, okay? Some insurance plans will cover the medicine, but it's still like $500 a month, so it's functionally uncovered. And then my personal favorite is Anchor Pharmacy. Some retail pharmacy that you can use that will help with the prior paperwork and that kind of stuff. They've been a huge help for me, so I send them all my prescriptions there almost always, and then they do the paperwork and help us out with that, and then they mail the drug to the patient. Tirzepatide, again, not technically FDA approved or any data to support cardiovascular disease yet. I think it will have that though. Basically, it has GLP and GIP activity, so it has a lot better side. So it's really interesting. So what was turning out with drug trials is that the more pathways that we hit, we're getting better weight loss and fewer side effects. So tirzepatide is kind of the first wave of this. There was a 3-hormone drug that just recently published their data as well. And so more weight loss, again, about 22%. This is Manjaro for diabetes, is Zepbound for weight loss. Again, no current CV data, hope is coming. It was recently FDA approved for sleep apnea. I have written dozens of prescriptions for that, and so far I've had 0 approved. So if anyone's doing better than me, let me know what do I need to do. But we'll see. Okay, cash pay. This changed actually quite a bit, like in the last few weeks. This is kind of interesting. And so Wegovy now offers a cash pay thing. It's a flat rate for those, $500 a month, so not cheap, but less than $1,000. And then Zepbound they have a very interesting plan, which we'll talk about now. This is LilyDirect.com. This is one of these 70 tabs I have open on my laptop all the time when I'm in the clinic. And I show this to people. And so they come in pre-filled vials, not an auto-injector pen, which is a huge deal. So it's the same volume for each dose. So depending on how small an insulin needle you can get, I guess, or syringe. So what I tell people is, look, we can prescribe you 5 milligrams if you can give yourself half that dose, okay? So now we've functionally made the opening dose $250 a month, not $500 a month. And a lot of patients have been taking advantage of that. Initially they only had the 2.5 and the 5 milligram dose. I love how they're like rolling back prices. Like it's like a Walmart sign on everything. So they did reduce prices though a couple of weeks ago. And they also have, they offered higher doses now. So now you can get 7.5 and 10 milligram dose. So again, I can prescribe you 5 milligrams and then go to 10 milligrams and you can continue to give yourself half a dose to get you 5 milligrams a week. Okay. Compounding, this is a semi-controversial topic. It's performed by specialty pharmacies. It's mixing one of the GLPs with some other thing. So it has to be mixed with something else. It's less available now. The FDA has kind of claimed down that the drug shortages have kind of gone away. And there are several professional societies, including those that represent physicians and pharmacists, that have put out statements saying you should not do compounding. I personally don't prescribe compounding. I don't know anywhere that I would send it to. I don't have that level of trust with the pharmacy. There have been issues with sterility, issues with what the other stuff is in there. There's not FDA oversight in this. We actually had a meeting with a clinic out in Arizona. There was a local pharmacy there that was mixing it with insulin, which seems like a horrible idea. It turns out they were having hypoglycemia, shocker. So anyway, so I don't do the compounding. I do branded or nothing else. This is my kind of final thing. Obesity is a chronic disease. So if we all lived in a resource-scarce place, we would all have the same BMI. Okay, if we all get strained on the same desert island together, yeah, we'll all have a BMI of 17. That's great. That's not where we live, thankfully. Okay, and so this is a almost entirely biologically driven thing. There are also it's terribly complex. There's some psychological issues as well. This is my thing on this. About 20% of people can lose 10% of their body weight and maintain that for over a year. 1 year, 10%, and that's it. So the data is very clear. I'm going to buckle down, doc. I'm going to, clean up my diet and I'm going to do some more treadmill stuff. That's great. I'm thrilled with those things. The data is clear. For almost everyone, that is not an effective long-term solution to this problem. Should you exercise? Absolutely. I tell people every day it's the most important medicine I can prescribe you, okay? But a medicine to help with this is just like taking a medicine for your cholesterol, a medicine for your blood pressure, a medicine for your thyroid. It is no different, okay? In my opinion. Obese people, they know they're obese. They're not shocked by this. They know this. So you telling them, hey, by the way, you're obese, you should lose weight, they know. What you should say is, hey, we're coming off you solutions. I think what we can do together to work on this. Their data is also clear. Almost everyone who is obese has tried and failed multiple diets multiple times. So again, it's not that this is new news for them or they've never tried before. They've done both a lot. And so, and advice on this is far more complex than you should eat less and move more. I tell people my view of this is telling an obese person who's chronically obese you should eat less and move more is like telling a smoker, well, stop buying Marlboros, dude. Like, obviously. So to me, as a non-smoker, that seems like the most obvious answer to quit smoking, just quit buying them. But obviously, again, the addiction is real. It's a real problem. And we have medicines to help with that, other adjuncts and therapies to help with that, including counseling, other stuff. So to me, in my opinion, this is the same thing. So that's why I tell people in clinic. They're like, oh, well, I'm just going to try to, or when they ask about like, hey, what if I come off the medicine, what am I going to do when I regain the weight? And you're like, well, yeah, about 80% of people do regain the weight. But because here's the deal. This is a tool to help you do a thing. So let's say that it's beautiful March Saturday, you got to go cut your grass. What are you going to use? You're going to use this or you're going to use these? So both of these things will cut your grass. Like, so why are we going to choose a lawnmower over a pair of scissors? Because one makes the job much easier to do and much more efficient to do. And so that's kind of how I put it to people, is like, this is just a tool to help us do a thing. It's no different. Okay, any questions about any of that kind of stuff? Oh, my time is okay. My heart was at 105. I'm on a smartwatch.